I'll now go on to Dr. Ashraya talking on indications for conventional inverted ILM and free flap techniques. So on to you, Ashraya.
So, good evening, one and all. I would be talking on indications for conventional inverted ILM peeling and free flap techniques in macular hole surgery. So, have no financial disclosures, and as Ridhima has already discussed in depth about the classification system, where the newer system have added the vitreomacular adhesion and vitreomacular traction to the full thickness macular hole. The earlier IBTS did give the classification to small, medium, and large, but the large, which is quite a bit of our macular holes, are more than 400 microns. The newer close study group further classified into large, extra large, extra large, and giant macular holes. So, as we all know, that partial vitrectomy with vital dye assisted ILM peeling is very safe and reliable procedure, which induces the closure of macular holes in up to 98% of the cases. But challenging cases like large macular holes and macular holes associated with high myopia are usually associated with poorer outcomes. And hence, in 2010, Dr. Michaelewska et al. Published their very famous inverted ILM, and then we had in 2014 the free flap techniques, which are most resorted as primary techniques in these macular holes. So, on consensus on the literature, whatever we have today, the most preferred technique up to 400 microns is conventional, and beyond 400 microns, the first reflex is to do an inverted ILM flap technique. And when it is more than 800 or 1000 microns of diameter, then we also tend to use the free flap technique. So this is the conventional ILM peeling technique, where after staining with the brilliant blue dye, with the use of the pinch and release technique, we initiate the ILM peeling. And once we initiate it, we peel it across the macular hole, relieving of all the tangential traction from the retinal surface. And once the ILM is removed from the macular hole surface, another 2 disc diameter of ILM is usually peeled around the macula, and the end SF6, so 20% SF6 gas is used as a tamponade. We are giving it a face down position. This is the conventional ILM technique, so which we use. So generally, this is one of my cases which improved with a good restoration of normal anatomy and the outer retina, improving from vision of prior vision of 2080 to 2030. So basically, conventional ILM is generally restores the anatomy of the outer retina, and we generally get good visual outcomes in about 96% of cases when the macular hole is in the range of 400 to 535, as per this meta-analysis of Renzende et al. But however, the closure rates drop down significantly if it goes beyond 800 to microns to 1000 microns. However, we have insufficient data on macular holes which are more than 1000 microns, but average visual gain is around 5 lines in cases with hole diameter of 400 to 535 microns. So, however, the large macular holes are not very uncommon. Based on this classification, we generally have around 50 to 60% of as large macular holes, and 5 to 44% of the large macular holes have been reported to remain open even after the primary surgery. The Chen et al. Reviewed around 251 articles and showed that inverted ILM flap treatment resulted in better closure rates and visual acuity when compared to the standard ILM peeling for large macular holes. So we all know this Michaelewska et al. It's a famous depiction of the technique of macular hole, where the ILM is peeling is initiated and peeled just to the edge of the macular hole, and around the macular hole, it is not peeled across the macular hole like the conventional technique. And once it is peeled till the edge of the macular hole, another 2 disc diameters of ILM is removed around the macular hole, and at the end, this macular hole is trimmed with cutter, so that the ILM flap inverts into the macular hole, and care is to be taken not to damage the RPE in the macular hole. So this is the standard technique as described by the Michaelewski et al. Group. And you also know that you get excellent visual outcomes and anatomical outcomes with this technique. And generally in the OCT, we usually see this kind of flaps lying for some time post-operatively. However, the free flap technique described by Morrison et al., who proposed the creation of free flap starting from the outer border of the complete ILM field area and then placing over the macular hole to cover it. So this was one case where the MLT was around 1600 microns, and in this case, it was also associated with tractional ERM, which we removed it. And once we removed it, we harvested one ILM free flap from the nasal part of the retina and placed it over the ILM. And to keep it intact over the hole, we used viscoelastic to stabilize it, and used gentle air fluid exchange and substituted with gas, SF6 gas. Post-operatively, the vision improved to 624 and remained at 624 even after 3 months. So this Vincent et al. Did pooled meta-analysis.
Doctor, 1 minute left.
Of these two techniques, and told that higher closure rates and better visual gains have been seen in macular hole, so with a diameter of 400 to 800 microns. So as we all know, a goal of the surgery is not to really close the hole, but to restore the macular anatomy and have a functional outcome. And mere closure of macular hole does not always result in a meaningful visual gain. So this is a case where we had a mere closure, but had only 660 vision. And in this case, we had a good V pattern closure with a good visual outcome of 6.9, where there is complete restoration of the outer retinal anatomy. So the take-home message would be conventional ILM peeling works well for macular holes of diameter up to 535 microns, and the inverted flap and free flap are the preferred surgical techniques for large macular holes that may improve the chances of a better anatomical and functional outcome in a single subject. Thank you.
Do you customize your ILM peeling, or do you have one technique for all macular holes, or is for the first time for a virgin macular hole, or you customize your ILM peeling according to the conventional, unless it's a very extreme sort of macular hole?
Sir, usually my go-to technique is only these two. Unless either I do come.
I am saying you have two techniques or you have only one technique. That is what I am asking.
No, less than 400, I just do conventional. If it is more than 400, I do inverted ILM flap for all holes, regardless of whatever associations.
So what's the logic for less than 400 conventional and what's greater than 400 ILM peeling? Or it's the other way around, that for the bigger hole you will require an ILM peeling? That is the logic, or that for conventional will work in only 400 micron? That is the logic. Why not do inverted ILM flap in 400 micron also? That is what I'm asking.
Since the data is there, so logically we can do for everything the same technique, but when you can as well attain great results with conventional ILM peeling, because the data speaks so. So it is not that we can't do like that. Both the things are vice versa, but we generally follow this norm. I would like to ask a few questions based on my images so that it becomes easier. So, what would be the technique of choice if this is the kind of macular hole we are having, high myope uh, with axial length of 32.82, and this is the kind of macular hole you would want to do. Is there we would definitely do inverted ILM flap, but is there anything we can do it manage in a high myope along with inverted ILM flap? I would request any of the panel members to say.
Yeah, I will start with that. I don't follow for all myopic macular holes are for inverted flaps, so irrespective of the size. So for all the myopic macular hole, irrespective of the size, I will do inverted flap. Yeah.
Yeah.
So, sir, do you do conventional axial length for all before? I mean, does AL plays in your any decision making, sir? Axial length, pre-operative axial length.
Does what? Sorry.
Pre-operative axial length, does it plays any role in your decision making?
Obviously, if I am able to make out the staphyloма and OCT is good enough to tell me, I don't need to get an axial length in every case. Actually, yeah, OCT will give me the real picture. Yeah.
Dr. Ahab, I guess you have a lot of high myopic cases in your practice. So,
well, let me first comment on the question that you got in the beginning. For all cases, you just remove the ILM, and for beyond 500, you do an ILM flap. I think now there is a lot of trials supporting this, but if you're going to peel anyway, there is no need to throw the ILM away, even if it's a 400 micron. I mean, if it fails the initial approach, I would rather have the ILM inside the eye as a flap, then I can reposit the flap, other than I say I just peel and throw it away and come with the next surgery and trying to find something else or a free flap to close it in. So the trauma that happened to peel the ILM already is there, whether you put it a flap or whether throw it away. So once I'm peeled the ILM, I'll just do it a flap, whether it's a 400 micron, whatever. Years ago, we were thinking that whatever you put over the macular hole will lead to the hole closure. In the era when we're just using serum, all this stuff, we're just keeping the hole away from the fluid until the normal anatomy starts to restore or have the triggering factors for hole closure to carry on. So the question is, should we just follow like it's a roadmap, remove if it's smaller, keep it in if it's larger? No, I think that now if you already initial the trauma of peeling the ILM, I would rather keep it inside the eye. You might need to reposit it later just in case if you have failure or whatever, and at the same time you have a higher success rate. Bringing this back to the question about the myopic holes, they are totally different because myopia is a progressive pathology. If you close the hole, it might open up later. And the challenge of the retinal stretching is very important. So in these patients, I always use flaps. And I think Dr. Leila will speak about the multi-layer flap, which is one of the techniques, which is my personal favorite technique. And I always use the technique that he'll be showing, into which we use multi-layer flap to make sure that you're covering the hole all over, and at the same time by more than one flap to increase your success rate. In myopic holes, I try to bring the peel as wide as possible, because the concept is not just closing the hole, but is trying to increase retinal elasticity as much as possible. The more you peel, the more the retina is free to start to recoil again. So myopic macular holes, I use a wide peel and a multi-layer peel.
Great insight, sir. So the bottom line is you can use one technique for all the macular holes.